So, as I said, I can hardly see you because of these lights, but what I'm going to talk about in these 5 slides are 2 aspects of management of bile duct injury. One is diagnosis, and the other is treatment. And I will pause on each slide to give you a chance to ask questions and make this interactive. So the goal of diagnosis of bile duct injury is to delineate the full extent of the biliary injury. And the second goal is to diagnose any associated vascular injury and to detect any resultant liver infarction. So those are the 2 goals, and it's extremely important to fulfill those goals, because if you don't and you find yourself in the operating room suddenly finding that you don't know where the ducts are, where the damaged ducts are, and you can't find them, then that can be a disaster. And doing a repair and leaving out a duct that isn't repaired means, in most cases, another operation to fix that. Also, it's extremely important to know the blood supply to the bile ducts that are left and the blood supply to the liver, how the injury has affected those things. So you need to figure all of that out before you go to the operating room, and then decide when's the right time to go to the operating room. So these are the tools that we have to make a diagnosis. MRI with MRCP, or a CT scan, ERCP, PTC, and retrograde cholangiography. One can also use ultrasound and biliary scintigraphy, but they have less of a role, particularly today. In the past, biliary scintigraphy was used as a screening test, but it's rarely used today because of the availability of better modalities for making the diagnosis. MRI is very attractive because it allows you to see bilomas and other things that are going on in the abdomen. You can see the blood vessels, especially the arteries, and often you can see all the bile ducts. But as those of you who were in my lecture yesterday heard me say, MRI has to be good MRI. And often in some centers, MRI is not as good as the CT that's available. So a good CT is better than a poor MRI. It'll show you the blood vessels. It's not very good for seeing the bile ducts, but a bad MRI is not good for seeing the bile ducts either. And even a good MRI, in our experience, does not equate to direct cholangiography when there's a complex injury with more than one duct that's injured. You just don't get the spatial resolution and the confidence that you can get in direct cholangiography. So how do you get direct cholangiography? Well, of course, you can stick a needle into the liver and get a cholangiogram, but that's often very difficult to do because you can't, the radiologist can't see the bile ducts fluoroscopically, and the bile ducts are often very small because the bile duct is cut and not occluded. So what we do is called a retrograde cholangiogram, and so most of these people either come to you with drains in place or they have bilomas that need to be drained. And if you leave those drains in place for 7 to 10 days, the biloma will contract around the drain. Then you can inject up the drain and into the biliary tree. And once you inject up the drain into the biliary tree and the radiologist can see the biliary tree fluoroscopically, then it's a lot easier to do a PTC. So this is a picture of an E4 injury. And in this particular case, as you can see, the right ducts and the left ducts are being cut separately. And we're injecting up the drain that's been left, and that shows us the right duct and the left duct. So that gives you very, very good anatomical evaluation of the injury, and now you know what you're dealing with. And usually in this kind of complex injury, we don't operate early because it takes a while to make the diagnosis. What we would be doing now is stabilizing the situation by doing a PTC and a U-tube. I don't have pictures of that this morning, but once you do the PTC, it can feed the tube through the liver down into the biloma and pull it out through the biloma tract, and you have a U-tube which is stable until the time of operation. So I'm going to pause here for a minute and see if you have any questions, anything you want to talk about in terms of diagnosis. Yes? Well, do we have a microphone here? Okay, that's good. Please all use, thank you. Please all use the microphones and you'll hear.
Good morning, sir. I'm Dr. Joseph from India. I was wondering if there is a chance of cholangitis if you're injecting through an infected biloma during retrograde cholangiography.
So you know when you ask a doctor a question when it starts with the words, is there a chance? The answer is yes. There's a chance, but we've done hundreds of these. We've never really had a significant problem. There's more of a chance of getting cholangitis when you do the PTC. If you begin instrumenting the biliary tree, there's more likelihood of cholangitis. But it's the kind of cholangitis where the patient gets febrile for 24 hours and then it goes away. It's never been a serious problem in our experience. Yes. Can you use the microphone? They're on both sides. Then everyone will hear you and we'll get a better... It's good to have a little walk in the morning, you know, so...
Sorry, can you hear me? I'm really interested in where exactly do you put this drain operatively? It looks like it's right at the cut end of the bile duct, where that drain is sitting, so it looks like that might be how you've got a beautiful cholangiogram. My other question is the technical aspect of putting in that U-tube. Do you have to go back operatively to pull it out through the skin again?
No. So the reason it looks like it's at the end of the cut duct is that if you put a biloma drain in, the biloma will contract around the drain, so you just get a tract, so it will always look like it's at the cut end of the biloma or a centimeter or two, cut end of the duct or a centimeter or two away. So what you do is you put the drain, then you put a PTC catheter in and feed it out the end of the duct and grab it with a snare through the biloma drain. You take the biloma drain out, leave a guide wire in, put a snare up there and pull the drain out through the abdominal wall. You end up with a U-tube.
So this is in the operating theater?
No, this is done in interventional radiology.
And what drain have you got there? Is that a Blake drain or a drain with a hole in it?
In that particular case, it's a Blake drain because that was left by the referring surgeon. But often there's a biloma, and when there's a biloma, you have to use a percutaneous interventional radiological drain, the drains that they normally use to drain bilomas.
Thank you.
Any other questions? Okay, I'll go on. So the second issue, is timing of repair. And this is very, very important not to get the timing wrong. So there's four things that are important, and three of them are obvious. You can't do a repair if you can't diagnose the injury. Many repairs many injuries are easily diagnosed. For instance, by MRCP, if you get a really good cholangiogram, for instance, and you see it's an E1 or an E2 injury, the common hepatic duct has been cut, you can see the right and left ducts, they seem to fill out the liver well, and the patient's referred on the same day or within 4 or 5 days, then you have the whole diagnosis and you can operate, provided there's not a concomitant vascular injury. By far the commonest injury is an injury to the right hepatic artery, and if you have an injury to the right hepatic artery, the common hepatic duct can become ischemic. If you operate early and do an anastomosis to that common hepatic duct, the chances of getting a stricture or even a postoperative perforation, that's uncommon, but a stricture is common. So you have to know if the right hepatic artery is injured, and if it is injured, don't do the repair early, or do a repair higher up. Do it to the left hepatic duct and not to the common hepatic duct. Very important to know if there's a vascular injury. Also, if a patient's referred 3 weeks after an injury and they've got a biloma, you're not going to operate on that patient because the inflammation would be too great. You drain the biloma. Even if they don't have a biloma, if they're referred 3 weeks after, better to wait 3 months or so until the vascular inflammation has subsided. And the patient might not be stable. There's 2 ways a patient can be unstable. The first way is that they're just sick from the biloma and an infection and peritonitis. Well, you're not going to operate then. But also, if it's an older person who's not doing well, or a younger person who has significant comorbidities, like cardiac failure or emphysema, things you have to get them tuned up for, you don't want to operate early. So that's an area on timing, and I'd be glad to answer any questions about that. So the principles of repair, and I'm going to talk for another 5 minutes and then turn it over to Dr. Fingerhut. The principles of repair are 2. The first is to identify all injured ducts, and that's a dissection phase. And we do this operation. The classic and still very good way of doing it is to dissect down the face of segment 4 until you get right down to where the ducts are, and then lower the hilar plate. You all know what lowering the hilar plate means. If you do know what's lowering the hilar plate means, put up your hands. So not everybody knows, but a lot of people know. And it means dividing the peritoneum at the base of segment 4, and then continuing to divide there until you divide the capsule of the liver, and you're actually in liver tissue. You're inside the liver. You can actually see liver tissue, and you'll have some bleeding from that. And then what you do is you can see the hilar plate, which is a fibrous tissue on top of the left hepatic duct, coming around the left hepatic duct. And you can pull it down and pull it into the field. And then find the left hepatic duct, because most of the time you will have a stent in the left hepatic duct for the PTC, and then you can open it. And so you need to identify all injured bile ducts. Sometimes the right hepatic duct is injured separately, and then once you find the left hepatic duct, you can go across in the same coronal plane as we described 20 years ago and find the right hepatic duct. And the principles of the repair are mucosa to mucosa repair, good blood supply, no tension, adequate size of opening, and fine absorbable sutures. And we use side-to-side anastomosis whenever possible, because then you don't have to dissect behind the bile ducts. If you open the anterior wall of the bile duct and sew to the anterior wall rather than sewing to the end of the bile duct, then you have less chance of inducing ischemia, because if you want to sew to the end of the bile duct, especially when the repair is done late, when you want to sew to the end of the bile duct, you often have to dissect behind the bile duct to free it, and that will devascularize the bile duct potentially. If you just find the front of the bile duct and open it longitudinally, you get a good opening, and you do not need to dissect behind the bile duct. Now, a long roux loop without tension is a good idea, but the important thing is without tension. It doesn't always have to be a roux loop. If you have a person who's had a lot of intra-abdominal operations, a hernia repair, and it's hard to produce a roux loop, you can do a choledochal duodeноstomy, but the duodenum has to be mobilized so it's not under tension. If it's under tension, that's bad. It's going to stricture or it's going to leak. So you can do a choledochal duodeноstomy, but you have to mobilize the duodenum and make sure it's not under tension. Of course, if you have an injury above the confluence of the right and left bile ducts, then it's hard to put the duodenum up there. It can be done, but you have to do it without tension. So if you have any other questions, I'll answer them now, or I'll turn it over to Dr. Fingerhut. Yes.
So in cases where there is a concomitant vascular injury, the right hepatic artery has been injured, lowering the hilar plate, would it cause any disturbance in the blood supply of the hilum?
No, it should not if you're in the right plane. The question is, if you lower the hilar plate and you have an injury to the right hepatic duct, the right hepatic artery, will it interfere with correction of the injury? If you're in the right plane, that's a good question. If you're in the right plane, the answer should be no. There is a very important marginal artery that runs right across the top of the confluence from left to right. That marginal artery is key in supplying one side of the liver with blood flow from the other side when the artery on the other side has been blocked. In other words, you block the right hepatic artery, what happens is that immediately through this preformed marginal artery, blood will flow from left to right and save the right liver. Now, if you can damage that artery, but if you do it lowering the hilar plate, that won't happen because the artery is inside the hilar plate. If you go outside the hilar plate, you won't damage that artery. By the way, that is key in doing cholangiocarcinoma operations where you're going to sew to the left duct. Stay outside the hilar plate, because if you're inside the hilar plate, you will damage the arteries supplying the end of the left hepatic duct. That's a very good question. Yes.
Is there any cases where you would choose not to do a side-to-side anastomosis?
Yes. That's a good question too. If you have a cut right posterior duct, that duct, when you discover it, is often running in the sagittal plane. It's going from posterior to anterior, and you can't open the anterior surface. You must sew to the end. You can only sew to the anterior surface when you can find the anterior surface. Abe?
I think you have another question, Steve. Steve? Sir, sorry.
Yes,
good
no
morning.
problem.
Actually, what is the left lateral limit of the dissection when we are opening the hepconod approach? Middle hepatic artery? Or sometimes middle hepatic artery, if it is very small, can we sacrifice the middle hepatic artery to get a good length of left-sided these things?
So that's also a very good question. It's an advanced question. There's an artery that supplies segment 4, whether it's a middle hepatic artery or not. A middle hepatic artery is an artery that supplies segment 4 that comes off the right hepatic artery. But there's always an artery to segment 4, whether it's a middle hepatic artery coming off the right or just the branch to segment 4 coming off the left. And that artery crosses in front of the left hepatic duct about 1.5 centimeters to 2 centimeters from the confluence. So as you open the left hepatic duct on its anterior surface, that artery is in danger of being injured. I don't think that would result in significant ischemia to the segment 4, because there's still portal blood supply and there's probably collaterals that would come from the other side. But it's an annoying thing to injure that artery. I've done it because it bleeds and then you have to sew it up. So you should be cognizant that there's an artery out there and feel with your finger, because you can often feel where that artery is. You can feel the pulsation of that artery and just stop short of it. The other thing you can do, if you only have a little bit of length, you can divide it and just get more length on the other side of it. But you're almost in the umbilical fissure there, so you have to be careful.
Thank you, sir.
Thank you.
Sorry, is there time for just a couple more questions?
Sure.
Yeah. The right posterior duct that's divided, and it's an early injury, it's recognized at the time of surgery, would you clip it or would you put a roux loop onto it?
Yeah, that's a good question. The answer is it would almost never be recognized at the time of surgery because that's, if you injure the right posterior duct, if it's aberrant and it's low, you'll be able to repair it by dividing it on its anterior surface. But if it's very high up in the porta hepatis, then that kind of injury, unless that's a kind of injury that would be referred to you to fix, you probably would never do that injury yourself because it means you're way away from where you should be doing a cholecystectomy. But yes, if you are an HPB surgeon and you do hepatocogegenostomies and you see it right at the time of surgery, then it's available to be repaired. So we usually repair everything that's bigger than a segment. So the right posterior sectional artery is 2 segments. We probably would try to repair it rather than clip it or tie it. The other possibility, if you can't do either, because that bile duct is going to stay open for a long time and drain bile, the other choice you have is doing a right posterior sectionectomy, just removing that part of the liver.
So you either bring a roux loop to it, could you close it with a T-tube primarily, or would it strictly?
If you mean over a T-tube?
Over a T-tube.
If it was high up, that would be really technically very, very difficult to do and unlikely to succeed. You mean an end-to-end anastomosis over a T-tube. You could maybe do that if there was a lateral injury to it, but if it's been cut across, probably wouldn't work well.
And one last question, bile duct injury, a simple bile duct injury, but in a small duct, and it's perhaps a diathermy burn with no other vascular injury at the time of surgery, and you're there at the time of surgery, no sepsis. I was just toying because of all these ideas of ERCP and PTC that seems to fix these problems. Is putting a roux loop side to side onto that, making that, bile duct still endoscopically possible, something that's done, or?
Well, it's endoscopically possible by percutaneous routes, but not by endoscopic routes. I mean, technically, an endoscopist could get around a roux loop, but the chance of success is low. But you can still go percutaneously. For instance, if you got a stricture there 10 months after you did the operation, that stricture could be ballooned percutaneously.
Thank you.
Morning. I have no slides. I'm going to be very unconventional. You've heard probably one of the most expert surgeons in bile duct management, bile duct injury management talk. So I would have very little to add. I'd like to just call on the audience, although I can't see you. One of my friends always looks in the audience and he says, every person should look to his left and to his right. So with you, your neighbor to the left, your neighbor to the right, one of you has had a bile duct injury or will have a bile duct injury if you're younger. So if I look around, and I also combine the fact that when Professor Strasberg said, who knows what lowering the hydroplaque means, I saw about half of you did not raise your hand. So my interrogation is that there might be people in the audience that are not expert hepatobiliary surgeons, but are here to learn what to do when the injury occurs when you're operating, when you're doing a cholecystectomy. If that is the case, I'd like to have some active participation of you, from you. What do you do when that happens, when you are operating? What is your attitude? Is there a rule when you're not an expert hepatobiliary surgeon and this injury occurs, how do you manage it during the operation? Now, if that is the case, I think there's a steadfast rule. You have to realize that you have to have some expertise to do these injuries in order to have a good result. And if this is not the case, do you have let's say, the mindset that is necessary not to do anything more, just to drain and get that expertise? I think that's a very, very important message, and I hope that there are some people in the audience that are looking for that information rather than the actual excellent ideas of how to diagnose, how to do the operation in a timely fashion and in a correct fashion. Now, my unconventional part of my talk is that I'm going to stop here, and I'd like to hear from you, somebody in the audience that has an injury. You can say it's your neighbor's injury if you don't want, and tell us how you manage that intraoperatively. Is anybody going to volunteer? No. Okay, can I volunteer? Oh, okay.
Hi, I know two cases. One I was involved in. The one I was involved in, there was a transplant surgeon in theaters. And it was me and another senior trainee, and we recognized the injury. So then the transplant surgeon scrubbed up, and we did a hep-jetch primarily. And it was a cut with the scissors rather than diathermy. So that was one case that I know. I don't know if
I'm sorry, what was the injury? Where was the injury?
So it was at the confluence between the cystic duct and the bile duct, and it was caused by scissors rather than diathermy. So then that was done a side-to-side anastomosis hep-jetch. Then the other case I know is referred, but in our region, we have an on-call HPB service, so we were then called to a tertiary, a smaller hospital. So when they have an injury, they stop, and then they call us, and we go an hour away, and we do a repair. So these are the two cases that I was involved in.
Okay, let's go back to that first injury. This was an injury with cold scissors. There was no energy-driven injury.
Correct.
Right? Okay. How many in the audience would agree with the fact that this injury was repaired immediately with an anastomosis of a Roux-en-Y?
Correct.
How many of you would agree on that? Do you have an idea how big the injury was? How large?
30–40% of across the duct. So it wasn't a clean cut. The whole duct was cut. As a trainee at the time, I thought we were just going to suture it, open or laparoscopic, but then I was told that will lead to strictures and it's best to do a hep-jetch.
40%? Okay, does everybody agree that that might be one of the consequences that would lead to doing a Roux-en-Y in the intraoperative? Do you have an idea how big the duct was?
The duct was small. I mean, it wasn't a dilated system.
Okay, so I did ask a question. How many think that this was an appropriate way of taking care of an injury that was 40% of the circumference, made by scissors, no energy involved, intraoperatively? I saw some hands going up there, but I didn't see a lot of hands. How many think that this was not the correct way and would have done something else? Okay, can I hear what you say? Go to the mic, please.
Good morning. I think less than 50% of the circumference can be managed with a good suture, with a 560 suture, absorbable suture. in a good way. I think, and if later you have a stenosis, you can repair on the stenosis with a loop.
Okay, I think there's a lot of people that might agree with that. But what about the idea that I put out? You don't have the expert, let's say, the HPV expert with you, and you're doing this operation laparoscopically. Would you still do this Roux-en-Y or convert? What would be the attitude here?
I've moved the mic to the middle of the room if it might encourage people to...
Good idea. Hello. They're going out. They're looking. Oh, the mic is over there also.
Yes, sir. The other option would be putting a T-tube in that rent if there is no expertise to deal with that injury. Or even if there is expertise, I would do a repair with a T-tube or a pigtail stent within the bile duct.
Okay.
So if expertise is not there, the one thing is we can put a drain, because if there is no bleeding, we can put a drain and come out. That is one option. If expertise is there, there are many options, as my previous colleagues has discussed, whether we can put a T-tube or we can do a primary repair, all these things. But what I realized is even if you are an expert and if you have injured, what I feel is there will be some kind of guilt in us. So I feel personally, even experience is there, better to call one more experienced person to do repair. That is my personal thing, sir. Thank you.
Okay, that's good. Okay, I think our time is running a little bit short. I'd just like to conclude that I think one of the major ideas that we have to have in this sort of injuries in the intraoperative, from the intraoperative aspect, is that the enemy of good repair, as you've heard, is going to be a patient who has inflammation or sepsis. So whatever you do, when you do something intraoperatively because you've discovered what the injury is, you want to have a mindset saying that if you have the expertise, okay. If you don't have the expertise, you do not want to make things worse, and you want to avoid postoperative sepsis, which is going to be a disaster for the patient until he gets the repair that he needs. I've finished. Are there any other questions? Our session is supposed to be over, I think, at 50. And it is 50. Are there any other questions? One last question.
What is the optimal timing of taking a patient with external biliary fistula who is passing white colored stools and is having a persistent external biliary fistula? What is the optimal timing of operating this patient, repairing the bile duct? Or what is the time when a patient is known to develop secondary biliary cirrhosis due to repeated episodes of cholangitis in this scenario?
Steve?
So, at least in Western countries, it's unusual to have a patient end up with an external biliary fistula that they're draining bile from months and months after the injury. But it can happen. And one wants to wait until the inflammation settles down before doing the operation. So that's a minimum of 3 months. And of course, you have to be careful when someone has a bile fistula, especially if they're older, that they don't get dehydrated, that they don't become acidotic. But usually that's not a problem. Unless the patient's quite elderly, then you can arrange for them to have intravenous nutrition while you're waiting. As far as the point where the person becomes cirrhotic, usually what happens is that it's one side of the liver that's damaged badly. That's the best scenario. And that's an indication for a right or left hepatectomy. That is usually the way that would be dealt with. And it's not just cirrhosis, it's recurrent bouts of cholangitis from the affected side. And if that part of the liver has been destroyed, doing an anastomosis to the duct coming from that side of the liver is not going to solve the problem. They'll still get more bouts of cholangitis because the ducts themselves in that part of the liver are no longer normal and they don't transport bile in a normal way. So you really do need to do a right hepatectomy or a left hepatectomy. Fortunately, that's very uncommon now. It usually occurs when the primary surgeon, who's not an HPB surgeon, tries to repair an injury, and then the injury, it doesn't work, and then they try to treat the patient with antibiotics, and they get they don't refer the patient after the first bout of cholangitis, they refer the patient after the 10th bout of cholangitis when that part of the liver has been destroyed. Fortunately, that's getting less and less common, but it still can happen.
Now, I'd just like to add that in that situation, my experience with these kind of patients in France, where I worked, is very, very low because, as you say, this is a rare occurrence. But most often when that happens, there's serious problems with the parenchyma. There's liver atrophy. There's a lot of things that the diagnostic workup has to be very, very, very well done, because more often than not, you're not going to do just an anastomosis, but you have a liver resection to take care of also.
One more question over here. Yes? No? Okay.
Just last question. In the case of a delayed repair, where the patient has to wait weeks or maybe months to be repaired, and you have a completely external drain of bile, will you consider to give the bile back to the patient for a nutritional aspect?
So I know that's been done, and it kind of makes sense because they can lose 800 or 900 cc's of fluid a day, and they also don't have the bile. If they have a complete fistula, they don't have bile salt, so they can't really digest fat. But in practice, patients don't really like that very much, feeding their bile back down a tube. You need to have access, so you could do it through a gastrostomy tube. And we have kept many patients for 3 or 4 months with a complete bile fistula, provided you give them some vitamin K and explain to them they have to replace their fluid losses with an electrolyte-rich drink. The only problems we've ever had is just in very elderly patients that become dehydrated. They may need some intravenous nutrition, but that can be done. You can refeed it, and there's nothing wrong with it. It's just a little messy.
And unpleasant. Okay, I think our time is up, and I would like to thank the audience for their participation, and have a good day.
Yeah, thank you very much.